Hello, everybody. I am Professor Michel Slama. I am working in the University Hospital of Amiens in France. And I would like to speak today about the relevance of the lung ultrasound in the diagnosis of an acute respiratory failure, and to discuss with you about the Blue Protocol. The Blue Protocol was described by Daniel Lichtenstein in 2008 with his publication on chest. And Daniel assessed the accuracy of the lung ultrasound to diagnose the patient with an acute respiratory failure, and to help the clinician by putting the probe on the chest on 4 points on the front of the chest and 2 points on the back on the chest. And he described many different profiles. First, the A profile with the A lines. A lines are horizontal lines, which are artifacts associated with a normal arid lung. And when he got bilateral A lines on the entire lung, so he called that the A profile. So he described as well the B profile. The B profile is associated with B lines. B lines is like a rocket line, like laser ray, which starts from the pleural line and is moving far away into the screen. And these B lines, if these B lines are bilateral, so he called that the B profile. So he called the AB profile when we have mixing A and B profile in one lung and in the other lung. As well, he describes the C profile, for which he describes the entire consolidation, and the PLAPS, which is a posterior lateral alveolar consolidation or pleural effusion. And then, using all these 6 profiles, he described this Blue Protocol. And for example, when he found a B profile, so it corresponds to a pulmonary edema. If he found the abolished lung sliding with a B profile, it corresponds to a pneumonia. And he really got a good accuracy, a good specificity, and good sensitivity using this Blue Protocol. You see that the specificity was very high, between 90 and up to 100%, and regarding the sensitivity was a little bit lower, but as well very high. Many different studies confirmed that the Blue Protocol is really useful at the emergency department with patients presenting with an acute dyspnea. This study included 383 patients. You see that the specificity is very high again, except for COPD patients, and the sensitivity is high, except for pulmonary embolism. Another study which demonstrates again that the specificity and sensitivity is high, except for the sensitivity in COPD patients. But the problem is, that we faced with the COVID-19 epidemic, and then we would like to verify that we may still use the Blue Protocol in patients with dyspnea at the emergency room during this period of time with COVID-19 patients. And then we included in this study 118 patients, 86 non-COVID and 32 COVID patients, and we analyze the accuracy of the protocol, of the Blue Protocol. And of course, we use the original Blue Protocol for that. And what we found that in 60% of cases, the Blue Protocol confirmed the clinical diagnosis. In 20% of cases, the Blue Protocol changed the clinical diagnosis in comparison with a final true diagnosis. But in contrast, in more than 20% of cases, the Blue Protocol failed to help the clinician and induce the false diagnosis. And then the diagnosis utility of the Blue Protocol itself at the emergency room during the COVID-19 epidemic seems for us a little bit limited. And so how to explain that we got so low accuracy of this blue protocol. For that, I would like to show you some CT scan of patients with pneumonia due to coronavirus infection. You see that most of the time the lesions are very severe, bilaterals. And you see here, for example, a very severe patient with the CT scan. And now, if you look at this study, assessing the CT scan findings, you see that in 100% of cases, they found a bilateral involvement, and in 100% of cases, they found a ground glass opacity, which gives B lines on the ultrasound. And you see that they analyze the ultrasound findings in these patients. And again, bilateral involvement was present in 100% of cases, and B lines were present in a very high percentage. In contrast, as you can see in this other study, even if the B lines are present in 100% of cases, the consolidation is present in 50 to 60% of cases, but pleural effusion is very rare, present in 22% of cases. So it means that in half of patients with COVID-19 pneumonia A, so we got bilateral B lines, as it was well demonstrated by few studies and by our studies. And then it means that if we have the B profile, so we may conclude that it is pulmonary edema and have then a fourth diagnosis, because the A and B profile is very rare in COVID-19 pneumonia A, and the abolition lung sliding is very rare as well. I would like to show you some example of lung ultrasound patterns in COVID-19 patients. You see here what we call the white line. It's merged B lines. Again, we analyze many different segments, and you have here a good imaging with B lines on left hand side and white lung as well. Here you have very obvious B lines. And if we look in a posterior position, so we have usually no consolidation. Here we are lucky because we got in another patient a big consolidation, and at that time, by using the blue protocol, you know that the patient has pneumonia A and not a pulmonary edema. So the main conclusion is that when you have a COVID-19 pneumonia A, so most of the time you have a confluent B lines or isolated B lines, sometimes pleural effusion and sometimes a subpleural consolidation. But one of the most important points, which was described by many authors assessing the COVID-19 pneumonia A, is that the pleural line is abnormal. And you see that the pleural line is thickened here, the pleural line is irregular, and most of the time, when you have this irregular and thickened pleural line, you may have a subpleural consolidation just behind this pleural line. Another paper demonstrated that we may have what we call a broken pleural line. It is not possible to follow the pleural line, and just behind this pleural line, you may have a peripheral subpleural consolidation, as you can see on this slide, and behind the subpleural consolidation on the right hand side of the slide, you may have as well a B lines. So that's very interesting to analyze in our institution the accuracy of the blue protocol during the COVID-19 infection, COVID-19 epidemic. And what we found is a lung ultrasound is very useful to diagnose COVID-19 lung lesions. We used to have bilateral B-lines. These B-lines could be merged and giving what we call a white lung, and this is a typical aspect that we got when we did a lung ultrasound on patients with COVID-19 pneumonia. But one point which is very important is to check for the pleural line, because if you do not check the pleural line, you may miss the diagnosis of the COVID-19 pneumonia, and the pleural line is broken, is thickened. And behind this broken or thickened pleural line, sometimes you may have subpleural consolidation, and all these lesions are the most frequent observed lesions. But in contrast, if you use only the blue protocol with the A, B, A and B, C, and Platts lesions and profile. So for us, due to the fact that most of the time we have bilateral B lines mimicking a pulmonary edema, it's not possible to use blue protocol. And then for us, the blue protocol failed to help the clinician at the emergency room. So I would like to thank you very much for your attention during this presentation, and hope to see you soon. Bye-bye.